which cannot be cured. So this one third will go, they are going to come and tell you that you treated and my vision reduced. So every 1 out of 3 is going to tell you this. So VR surgeons are needed. So how I counsel, I will show some my collection of cases. So because in my case I do laser, I do surgery, so that is no problem. So I tell, if it is not working, I will do surgery. That is okay. But this is not possible in a medical retina. Like DME not responding to treatment. You give 1 injection, 2 injection, nothing is happening. Look at the OCT. There is a epiretinal membrane or a taut hyaloid. How much ever injection you give, it is not going to worsen, improve. So that biomarker or epiretinal taut hyaloid in the OCT, that will tell you even if you inject. So these cases will require vitreoretinal surgery at a later date depending on the visual acuity. So this is not going to respond. Now this is another case of vitreomacular traction. How much ever, just see the OCT little carefully, see whether there is any taut hyaloid or membranes which will prevent reduction of, and never treat based on central macular thickness. Again and again I tell in every forum, don't treat that central macular thickness. That is not the thing. The configuration of the retina and the findings like this in biomarkers are more important than central macular. So this is post operatively you get. So these sort of cases, be careful before keeping on injecting. 1 or 2 injections, they are likely to worsen also. Then there is something called recalcitrant macular edema. You inject 2-3 times, fine. Before treatment was left side, after treatment you can see the edema is little less, but hard oxalate has increased, right? So this sort of recalcitrant, after 3 injections, if the vision and edema is not reducing, probably you have to reconsider, either switch a drug or refer to vitreoretinal surgeon for vitrectomy. Many of these cases, recalcitrant edema likely to improve with vitrectomy. Taut hyaloid, this is very dangerous situation. You see white area, not blood, that is fibrous tissue, they are likely to worsen with laser. So preoperative and postoperative, these cases will require surgical intervention. Then this is another case, free macular fibrosis. This is called pre-macular fibrosis, that white area. So these cases, all not only DME, PDR cases. So this case, if you give, what will happen if you give pan-retinal photocoagulation? The vascular element will become more fibrosed. So the fibrosis increases, macula will become more bad, vision gradually reduces. So if such a finding is there, pre-macular fibrosis, VR surgeon may be needed. So this is pre-operative and post-operative. Now this is another case. Already bleed is there, hard oxalates and pre-retinal bleed. Most probably this will end up with surgery. So probably medical retina person can give little laser and 1 month later see and then refer. Already tell the patient this will require surgery. We will try to give little laser and see after 1 month. So this is another thing. Now clearing the media, that is another area where VR surgeon is required, like asteroid, recurrent vitreous hemorrhage, but you don't see anything. It is very difficult to give laser also. Angiogram is a very useful modality in this. Cataract, vitreous hemorrhage and DME. Lot of patients come like this. There is cataract and DME is there and maybe little vitreous hemorrhage. These cases, ideal method is either you do cataract surgery, then refer it to VR surgeon for vitreous, or single stage you can do whole thing together. So these are all cases where VR surgeon may be needed in this. So this patient underwent cataract surgery with vitrectomy and additional laser, and this lower one right side is the final follow-up. So they do well with systematic treatment. So post phaco IOL vitrectomy, this is another case, left eye, in the OCT there is a taut hyaloid. So post surgery, even though the hard oxalates are the lower one is a post-operative 6/12 post phaco IOL vitrectomy. So these are combined cases which we do to improve the vision. Then scene 4 is PDR likely to worsen. You give laser, then he starts bleeding. So these cases, especially if you see a bad big new cells in fluorescein angiogram, be careful. You have to take Mungur Jamium before starting treatment. So that is important, because patient will not understand the theory, all these percentages. So this is a important case that I always show. There is a huge NVD actually, and 6/6 vision. And these are really, after PRP, 1 week later patient came with the right side picture, 1 week later. So very difficult to deal with these cases. So you have to talk to the patient initially, and this is another pre-treatment in left side. Post PRP, you can see that blood has become white, that is fibrosis. Neovascular element has become fibrotic. So this patient gradually lost vision, and then we did surgery. Crunch phenomenon is another thing. Many of us give excessive laser in heavy burns, and immediately 6/6 has become hand movements in 1 month. Crunch phenomenon, the whole thing contracts and detaches. This requires immediate surgery. So these are not easy cases. So crunch phenomenon, and there are cases like this. It is going to worsen fibrous tissue and new vessels, and so these cases you have to initially itself take the opinion of VR surgeon. And extremely ischemic retina, all these cases, and taut hyaloid fibrosis, premacular fibrosis. This is another case that I show, bomb in the eye, 6/6 N6. Luckily we had in fact, after the macula there is no perfusion, the whole area is ischemic. So 6/6 vision. So written consent also, we did laser and everything, and ended up with surgery. Both eyes oil removal, and over many years he is maintaining some 660. So with good communication. And scene 5 is already there is a vitreous hemorrhage surgical case. Probably a medical retina specialist can give little laser and then refer to the surgeon for further management. Recurrent vitreous hemorrhage is another indication for vitrectomy. Especially once or twice you can wait 1 month, 2 months and give additional laser if possible. Otherwise it's an indication for surgery. Combined RD, absolutely no option other than surgery. Then TRD involving or threatening macula is theoretical indication. Yesterday also in one forum I said, actually this patient is maintaining vision for past 7-8 years with 6/18, 6/24. These sort of stable cases we need not do a surgery. So in one visit itself, don't decide all these things. And another thing is, I have 1 or 2 minutes extra. No problem. No? So another thing is, if a patient comes with one eye bleeding and the other eye has a PDR, you have to tell the other eye requires treatment, but don't give that priority, because the patient has come for this eye. In fact, one of my colleagues gave right eye vitreous hemorrhage, left eye PDR. Right eye anyway we have to wait. By the time he started left eye surgery, left eye laser. 1 week later, patient came and told me, by mistake they gave laser in the other eye. I came for this eye. It's a communication problem. It is actually other eye also has PDR, but give priority. Talk to the patient and give priority. Which eye to treat is more important. So take-home messages are, we need medical retina specialists in India to tackle diabetic retinopathy burden. Smart India program was there yesterday. The incidence and prevalence, everything, huge volume. It is millions in India. And we need medical retina people, but medical retina people should work in tandem with retinal surgeons, and they should understand their limitations, but they should do a good work. Now, unfortunately, in the last, with the advent of biosimilars, the rampant use of anti-VEGF has worsened the scenario. 20 years back, I used to get fresh PDRs like some of these. Nice PDRs. I treat with laser. If it worsens, I will do surgery. Now all of them are coming with bad combined RD or late stage, advanced stage, because of irregularly and improperly managed diabetic retinopathy. So that is what we don't want. So, and finally, the last line, communication skill is the most essential quality in any practice. Biju was talking about yesterday about the ethics and etiquettes and everything. After all, it is a teamwork. Thank you very much.
Thank you, Dr. Mahesh, for that excellent talk and the practical tips on how to proceed in different and difficult situations. Information from hardcore VR surgeon was definitely beneficial for all of us. And the next talk is by Dr. Manju Abraham, Professor and Head of the Department, Government Medical College, Ernakulam, about picking them early and right, screening protocols and management of risk factors.
Thank you, Dr. Danya. We move on to a less stressful topic. Nonetheless, it's very important, the risk factors and screening protocols of diabetic retinopathy. So the risk factors may be grouped as modifiable and non-modifiable. The non-modifiable are the duration of the disease, age of patient and genetics, Modifiable are the blood glucose levels, the blood pressure, serum lipid levels, microalbuminuria, and others like pregnancy, puberty, and anti-diabetic drugs. So we know that the retinopathy prevalence have come down now with a better control of our modifiable risk factors. Now let's consider each one of them. Two landmark clinical trials, the DCCT and the UK studies showed that intensive glycemic control reduces the risk of development and progression of DR. It is noted that a 1% decrease in HbA1c can reduce retinopathy development by 40%. And an early intensive control has benefits that last for up to 10 to 20 years, and we call it the metabolic memory. So it's it's recommended to keep the HbA1c levels less than 7, and earlier it is achieved, the better. Now, the Wisconsin epidemiological study showed that in type 1 patients, diastolic BP is a predictor to the progression of retinopathy. And the UK studies and the Euclid studies showed that every 10 millimeter increase in systolic BP can cause a 10% increased risk of early DR. And the study also showed that ACE inhibitors and beta blockers reduce the risk of DR. So our target BP should be less than 140/80. Now, what about dyslipidemia? The ETDRS showed a twofold increased risk of heart exudates when the cholesterol levels were more than 200. The beneficial effects of fenofibrate was seen in the field and the ECHORT studies, where there was a reduction in the DR progression as well as a need for laser photocoagulation. So it's ideal that you keep the cholesterols less than 200, triglycerides less than 150, and LDLs less than 70 in a high-risk patient. Now, coming to renal disease, in a prospective study done in type 1 patients, the risk of PDR increased from 7% to 24% after 4 years of onset of microalbuminuria. And the study also showed that gross proteinuria at baseline is associated with a 95% increased risk of DME. A decreased GFR as well as an increased urine albumin creatinine ratio significantly correlated with diabetic retinopathy prevalence. And if you see that in a previously stable retinopathy patient, a rapid progression is noted, the patient definitely needs a renal evaluation. And we also see that retinopathy remains stable in patients who are undergoing dialysis or who have already had a renal transplant. Now, what about diabetic medications? The DCCT showed that in the first 2 years after initiation of an intensive insulin therapy, the retinopathy can worsen transiently. So these people require careful monitoring every 3 months for the first 6 to 12 months. And you can even consider PRP before starting an intensive insulin therapy if the retinopathy is severe NPDR or early PDR. Now, the glitazones also increase the incidence of DME by 2 to 6-fold. These patients also require an adequate follow-up. Now, what about pregnancy? Retinopathy can rapidly progress during the second trimester. The effect may be transient. Women with the poorest glycemic control at baseline and those needing the greatest reduction in HbA1c in the first trimester are at higher risk of retinopathy progression. So it may be appropriate to perform a PRP before conception in severe NPDR patients to prevent further progression. Now, others like a hemoglobin less than 12 is associated with a twofold increase. A high BMI is also associated with a severe diabetic retinopathy. Now, the non-modifiable risk factors, we know the duration is the most important. The Los Angeles Latino studies found that each year of diabetes is associated with a 8% increased risk of retinopathy, and men are at an increased risk. Now, the second part of the talk is on retinopathy screening guidelines in India. The AIOS, Diabetic Retinopathy Task Force, and the VRSI have initiated measures to improve the screening in India so as to identify sight-threatening retinopathy early and to treat it promptly to prevent blindness. At present, there are about 3 million people who are at immediate risk of visual loss due to sight-threatening retinopathy. We have a high prevalence of undiagnosed diabetes in India, so we cannot restrict our screening to the known diabetic patients alone. So what AIOS have recommended is, though it is made appear not practical, all people with known diabetes on treatment or a single record of RBS more than 200 or an HbA1c more than 6.5 or a gestational diabetic, when first seen by a medical professional, should be advised a retinopathy screening. And the Government of India has also introduced a non-communicable disease register where the data of all diabetic patients should be entered, and these patients should be called for periodic screening. Now, how do we screen these patients? We have a community-based screening where screening should be done to all diabetic patients who attend the NCD clinics at the PHCs. We can do opportunity screening at the physician's clinic or the diabetology clinic, which appears to be the first point of contact for the patient. There are community outreach programs where door-to-door screening can be done to identify retinopathy patients. You can conduct exclusive retinopathy camps, and also you can screen at primary vision care centers. Hospital-based screening means diabetic patients that are seen at other departments are referred to the ophthalmologist. Now, the most practical way is a fundus photography by a trained technician using a non-mydriatic camera that gives you a wide field and which gives you high resolution images. All the captured photos are transferred to the base hospital. Now, if the technician can identify retinopathy, those images alone are sent to the base hospital. Now, if the technician is more confident and competent to grade the retinopathy, cases that are identified as more than mild NPDR are sent to the hospital. There, the ophthalmologist sees these images. A report is sent back to the NCD clinic or the diabetic clinic, and patients with sight-threatening retinopathy are asked to report to the main hospital. And the ophthalmologist should also see at least 10% of the normal images just to cross-check. Now, if the quality of the picture is poor, it may be due to the cataract or a small pupil. Those people should also be sent to the base hospital. Now, when do you screen them? A type 1 requires screening within 5 years of onset of diabetes. Type 2 at the time of diabetes diagnosis and then annually. Gestational diabetes does not require examination. A patient with a pre-existing type 1 or type 2 planning to conceive needs an eye examination prior to conception and should be monitored at least once every trimester or more if there is, depending on the degree of retinopathy. Now, the follow-up guidelines are no DR or a mild NPDR every year, moderate NPDR 6 months, severe every 3 months, PDR with no high-risk characteristics every 2 months, a center involving diabetic maculopathy with good vision every month, a non-center involving with very good vision or every 2 or 3 months. Now, if seen by an optometrist, a patient with severe NPDR, PDR or a diabetic maculopathy should be immediately referred to the ophthalmologist. Now, to sum it all up, the ophthalmologist should ensure a timely detection of STDR by a periodic screening. A prompt treatment should be initiated to prevent blindness. You educate the diabetic patients and create a public awareness on this blinding condition and refer the patient to the physician for better control of the systemic risk factors and other complications of diabetes. Thank you.
Thank you, ma'am, for stressing the importance of screening and risk factors of diabetic retinopathy and its treatment, the essential essence of this IC. Well, what is currently trending everywhere is artificial intelligence, and we don't want to miss out on that. Inviting Dr. Sindhu NM, Associate Professor, Government Medical College, Ernakulam, for a talk on the same.
Good morning, everybody. I'm Dr. Sindhu NM. I'm going to talk on artificial intelligence in diabetic retinopathy, exploring AI's role in early detection and treatment. According to ICMR India Diabetes Study published in 2023, the prevalence of diabetes in India is 10 crores. And according to the Smart India study, the study found that prevalence of diabetic retinopathy is 12.5% and with 4% having severe diabetic retinopathy. So, what are the challenges in diagnosis of diabetic retinopathy? A regular and repetitive annual retinal screening in all patients with diabetes mellitus is needed, which includes a detailed dilated fundus examination done by an ophthalmologist and with color fundus photography taken by a technician or optometrist, which has to be analyzed and graded by retinal specialist or ophthalmologist according to ETDRS grading guidelines. So, the number of doctors, number of ophthalmologists or retinal surgeons in comparison with the patient load is very less, and there is limited access to specialized care, especially in remote areas, and the high cost of eye exams and subjectivity and human error in interpreting the images are the major challenges. So why AI? The screening itself helps in avoiding blindness among 90% of patients with diabetic retinopathy. So providing an automated imaging system within the easy reach of the patient and developing automated analysis software using computer machine learning or artificial intelligence for analysis of retinal images in patients with diabetes itself will solve some part of the problem. What is artificial intelligence? Artificial intelligence is a simulation of human intelligence processed by software or machines, especially computer systems. In simple words, it means to accomplish a task mainly by a computer or a robot with minimal involvement of human beings. The types of AI includes machine learning, deep learning, and neural networks. Machine learning algorithm identifies patterns in data and make predictions based on those patterns. Whereas deep learning is a subfield of machine learning which is particularly effective at learning from large amount of unstructured data like images, text, or audio. All the AI system needs a proper training and validation. The AI system start by learning from a database with the simple targets. After this, they are trained to improve, becoming more accurate and efficient. This is done by bombarding the AI software cloud with a large amount of data, and they learn to identify from seeing the pictures, and by improving training, after training, the validation process done. Using advanced math and neural network, the system can understand complex relationship between variables and evaluate different possible outcomes. So in diabetic retinopathy, firstly, the machine, after being exposed to a lot of annotated images, learns to grade, identify and grade diabetic retinopathy by itself. The software can automatically analyze retinal images and provide the grade and severity of diabetic retinopathy and referral recommendations. So in the clinic, when a patient comes to you with the diabetic retinopathy, the technician can take a fundus photograph, and these fundus clinical photographs are uploaded into the AI software cloud, where this software itself identifies diabetic retinopathy and classifies and grades and whether it is referable or non-referable, or with diabetic macular edema or not. And this diagnosis we can it's sent to the clinician sitting in the clinic. The clinician can provide a counseling regarding the condition of the patient, or if needed, refer to the higher center. So the effort or manpower taken will be very less than the routine examination done by an ophthalmologist. What are the techniques used in diabetic retinopathy diagnosis? It's AI-based systems that detect retinal images using standard 2D images, or AI algorithms assess the OCT scans for retinal thickness and structure changes, or AI-driven software helps in automated screening, improving the efficiency in large-scale screening programs. The advantages of AI in diabetic retinopathy includes early detection, accuracy and consistency in getting the results, and the cost effectiveness and scalability. The case studies and real-world applications, and IDX-DR is the first FDA-approved AI system for detecting and grading diabetic retinopathy. And Selena is a Singapore eye lesion analyzer. It's used in their national program of Singapore for grading diabetic retinopathy. And Arvind in India, Arvind Eye Care System already started AI system along with telemedicine for screening diabetic retinopathy in underserved regions. So in addition to diagnosis and screening, AI is useful in staging and classification, lesion analysis, functional assessment, personalized treatment planning, and progression prediction. The challenges in AI in diabetic screening includes the need of high sensitivity to sight-threatening diseases, the high specificity to limit the false positive referrals, and a good data quality is used for validation and training. Generalization into the diverse population are still under struggle. Regulation and ethics regarding the patient private data privacy, and integrating the health with the existing healthcare system is another challenge. The future directions, the ongoing advancement in AI and deep learning models will improve the accuracy and diagnostic capabilities. Integrating with telemedicine and AI can provide a personalized treatment plan depending on the patient data. To conclude, AI is offering a more accurate, cost-effective, and accessible care. Early detection through AI can prevent vision loss and improve the patient outcomes. The future advancement in AI will continue to enhance the healthcare for diabetic retinopathy patients globally. Thank you for your patient listening.
Thank you, Sindhu. Now we have a few minutes left, inviting any questions from the audience. So we understand that. Yeah. So we understand that our session has been quite enlightening. Thank you all for coming this early and making our session a success. Thank you.
Hope this instruction course will help improve your techniques of CCC and make each one of you a more confident and better cataract surgeon. Let's start with the first talk, The Perfect Capsular Access, Principles and Techniques by Dr. Kirtana Sakariya. Dr. Kirtana, after her post-graduation and phaco training, has worked as phaco surgeon at Mother Care Hospital, Palakkad. Currently, she is in the process of building her own practice at Ernakulam. Over to Dr. Kirtana.
Thank you, ma'am. So, good morning, everyone. We'll start the session with a very basic topic, the principles and techniques of a perfect capsular access. So, why do we actually need a continuous curvilinear capsular access? So, CCC rim is mechanically more stronger as compared to a capsulotomy rim, and it has less risk of tearing during chopping maneuvers. And it has no flaps or tags which can get stuck between the instruments. Also, it gives a better IOL positioning. Now, what are the principles while we make a CCC? So, basically we are making a circular opening on the anterior lens capsule, and in doing that we are making use of certain forces. So, let us understand those forces briefly. So, first is a shearing force. So, in simple terms, it is a force that we use to tear a paper, as I have shown in this illustration. So, on one side there is a flap and we fold it over and pull it in the direction in which we want the material to tear. So, when it comes to capsular access, we are using this shearing force along with the force that is directed towards the center of the axis to get a circular trajectory. So, these two forces have to be balanced to get a circular trajectory. So, that is the main principle. Now, we also use a ripping force sometimes. So, here we are holding a paper on both sides and pulling it apart. So, the force is applied perpendicular to the direction of the tear rather than in the direction of the tear. So, this force is mainly used while we are rescuing a runaway axis. So, these are the main forces that we use. Now, regarding the ideal sizing of a capsular axis, so the CCC should be large enough for easy nucleus removal and IOL implantation. At the same time, it should be small enough to maintain the capsular integrity. So, if you are doing phacoemulsification with a foldable IOL implantation, then the ideal size would be around 5 to 5.5 millimeters, so as to get a small optic overlap by the rhexis rim, since most of the foldable IOLs have an optic diameter of around 6 millimeters. So, this gives a better IOL positioning and reduces the chances of posterior capsular opacification. Now, if you are doing SICS and you have a large and dense nucleus, then you require a larger rhexis. And also, if you are operating on an intumescent cataract, then you might require an initial smaller rhexis followed by enlargement later. Now, if you are a beginner, you can use a rhexis marker if you want to guide your rhexis size. So, this is a corneal rhexis marker. It has two rings. The inner ring has a diameter of 5 millimeters and the outer ring has a diameter of 6 millimeters. So, you can make a corneal impression with this marker and you can do the rhexis between these two rings. So, you get a diameter of around 5.5 millimeters. Now, regarding the instruments that we use for CCC, you can use a cystotome or forceps like Utrata or microrhexis forceps. So, the most easily available, the most commonly used and the most basic instrument is a cystotome. So, in this talk, we will be discussing mainly about the technique of capsular access using a cystotome. So, how do we make a cystotome? So, we use a 26 gauge needle for this. You can attach it to a 2cc syringe or a tuberculin syringe. And it is always advisable to bend the needle under microscope in good illumination and high magnification, keeping it focused on the needle correctly. So, keeping the needle in bevel up orientation, hold the needle at the bevel with a good needle holder and bend 1/3 of the length of the bevel downwards to an angle of around 70 degrees. Now, keeping the needle in the same orientation, the second bend is made towards the hub of the needle upwards to around 60 degrees. So at the tip, we are making around 70 degrees of bending, and towards the hub, we are making 60 degrees of bending. So these are approximate angles, and the second bend the angle of the second bend can be slightly modified according to the depth of your AC. If you have a deeper AC, you can bend it lesser, and if you have a shallower AC, you can bend it little bit more. Now, before starting the surgery, make sure the surgeon is positioned comfortably with a straight neck and back. He should not be crouching or hyperextending his neck to get a proper view through the microscope. And the patient head positioning is equally important. The chin and forehead should be at the same level, parallel to the floor. If the chin is tilted downwards, you can tilt it slightly up to maintain the position. And if the neck is hyperextended, then you can keep a folded towel or a ring under the head to maintain the correct position. Also, the head should not be tilted to either side. Now, hand positioning of the surgeon, the elbows should be making an angle of approximately 90 degrees. And the most important point is that the hand should be supported at the wrist, and you should be holding the cystotom like a pen. Now, regarding the surgical steps before we reach capsulorhexis, so the side port incision should not be very wide. It should be ideally less than 1.5 millimeters so that it causes less leakage of visco when you are doing the capsulorhexis. Now, the next important step is staining of the lens capsule. So, this is done for proper visualization during capsulorhexis. So, it is always advisable to stain the capsule if you are a beginner or if you have a poor red glow, as in dense or mature cataracts. So, the dye that we use is trypan blue. So, what is the technique of staining? You first inject an air bubble into the AC and then inject the dye under the air bubble into the AC. And this is done to decrease the exposure of the corneal endothelium to the dye, and after waiting a few seconds you can wash out the excess dye with BSS. So after staining, you should be having a uniformly stained capsule. The staining should not be patchy. Now you can also do your rhexis under retroillumination by turning on the red reflex button on your microscope if the cataract is not very dense or mature. So you'll be seeing the rhexis rim as shown in this video when you are not staining the capsule and doing it under retroillumination. But for beginners, it is always advisable to always stain the capsule rather than using retroillumination alone. Now the next step is to fill the anterior chamber with OVD. So why do we actually need this step? So when the AC is adequately filled with visco, the radial forces applied by the zonules on the anterior lens capsule is much less. So the chances of rhexis running to the periphery is decreased and you get good control while doing the rhexis. So the OVD most commonly used is 2% HPMC. You can also use cohesive OVD if the AC is very shallow. So cohesive OVDs maintain space much more than HPMC. So if you have a shallow AC or if you need to enhance the pupillary dilatation a little bit, you can use cohesive visco. Now while injecting visco, make sure that you inject it from inside out so that the AC is adequately filled. Then you can also put a little bit of visco on the cornea so that the cornea doesn't dry up very easily in between the rhexis. Now you are ready to start your capsulorhexis. So first introduce your second instrument or the dialer with your non-dominant hand through one of the side ports. And this second instrument helps to keep the eye stabilized in the central position. Now you can introduce the cystotome with your dominant hand through the other side port. So when you are doing this, make sure you tilt the cystotome sideways before entering so that you do not injure the side port. Also, this has to be taken care whenever you are entering or exiting the eye with the cystotome. And also make sure that you do not press the posterior lip of the side port while doing the rhexis because that can cause more leakage of visco. Now, after entering, make the initial puncture on the anterior lens capsule at the center and then extend this incision radially for about 2 to 2.5 millimeters so that you get a final diameter of around 5 to 5.5 millimeters. While doing this, avoid digging in and disturbing the cortex because that can make the flap identification difficult. Now, you raise a capsular flap, fold it over itself and direct this flap in a curvilinear fashion to get a circular rhexis. So, how do